I'm so glad to be here. I'm honored, and I want to say something that really is not in my notes, but may or may not be of importance to you, the mother, the father, the child who pulls, the adult who pulls. But all three of us are coming together today because we know so much about trichotillomania. I have trichotillomania, and I've lived with it since I was 15. And Christina has trichotillomania, but she has been pull-free for years. Dr. Pauls is one who saw our immense hunger for help in this field and said yes to Christina when Christina asked him for help. So I want you, the mother, the father, the puller, I want you to know that we are coming to you with decades of experience, and we're talking to you from the depth of our heart today. And we just hope, beyond hope, that you will not run from what we have to say, but take it in and see if something that we are sharing with you applies to your life. Okay, with that said, I'd like to start with my first question for Dr. Pauls. And thank you from my angle for being here. I so appreciate it. You all should know that my relationship with Dr. Pauls goes back to approximately the year 2000, when we had our first talk about what study might be done to further the understanding of trichotillomania. My first question for Dr. Pauls today has to do with his background, so you can know more about what he studied to prepare himself for his life work. So Dr. Pauls, would you please tell me and tell the audience a little bit about your educational history, where you went to school, what areas you have degrees in, and in general, what you studied?
I'd also like to start by saying it's really a pleasure to be here. I consider the both of you as being really good friends, and so it's going to be a fun experience, I think. Getting to your question, I got my bachelor's degree. Actually, I got two majors from Fresno Pacific University in Fresno, California. I majored in mathematics and also in natural science, which was really a combination of biology and chemistry at that university. Just as an aside, I only became interested in genetics because I had finished my math degree after 3 years and I didn't want to leave college yet. So a professor there encouraged me to take his beginning genetics course because it was applied mathematics, as he said. And it was because of that course that I ended up being in the field of genetics. After I graduated from Fresno Pacific, I went to graduate school at the University of Minnesota, first as in a graduate program in mathematics, and I got to the master's level and decided to switch to genetics or population genetics, human population genetics. And so my degree, I have a degree from Minnesota in, it's called genetics, cell biology actually, genetics and cell biology. But my focus was always on human population genetics, looking at disorders in the population and trying to understand what the genetic factors might be for them. And I've always been interested in behavior. And so my dissertation was really on cultural mental retardation, familial cultural mental retardation. But then after that, I began to study more psychiatric disorders. After teaching, and then after my PhD, I actually went back and taught at Fresno Pacific for 6 years. But after teaching there for 6 years, I then got a postdoctoral fellowship at the University of Iowa, and that's where I really began to focus on psychiatric disorders. In fact, the first family study I worked on was one for anxiety disorder. And then after that, I got another postdoctoral fellowship at Yale, and there was involved in a family study of depression. Once that was done, I then got a position in the Child Studies Center and became really focused on childhood disorders.
What were your initial thoughts about the disorder of trichotillomania, and how has your thinking changed over the years, if it has changed?
Well, first of all, I didn't know what trichotillomania was when she approached me. I mean, I had some inkling, I knew what the word meant, but I really had no idea of what the disorder entailed. I also thought it was an extremely rare disorder, because of course I had never seen it, so it must be very rare, right? As I worked with the Scientific Advisory Board and the TLC, it became apparent that it wasn't as rare as I had thought, and that it also was a much more complex disorder than just pulling out your hair. That many of the sufferers also suffer from a variety of other conditions which only adds stress to their lives. So it's completely changed how I think and what I know about trichotillomania by being involved in the SAB.
David, would you go over what you wanted to do in that study, what you thought it would achieve, and what came out of the study? That's a mouthful.
Yeah, that is. And do you have a couple of days?
We could break it down and just say, what did you want to achieve?
Well, I want to begin by saying that a family study is designed to obviously learn more about how trichotillomania manifests itself in the family, and partly because I was a geneticist, I am a geneticist, I wanted to know if it was indeed familial, whether it was passed on from parent to child. But in addition, because there had not been any large enough study to really characterize the clinical phenotype of people with trich, we wanted, part of the goal of that family study was to do a very comprehensive evaluation, a long interview of the people who had trichotillomania and their relatives, to see whether there were any other conditions that tended to go together with trich. And then the final goal was to evaluate the family environment. We had some knowledge that stress makes almost everything worse, and we imagined that stress would also make trich worse. So we wanted to know something about what the family environment was like, what the parent-child relationship was, what the sib-sib relationship was. And so we also had a very extensive battery of measures that delved into some of the social emotional events and other environmental events that happen in a family. So what we accomplished, I think I'll talk about a little bit later, but we found out that indeed trichotillomania does run in families, and we found out that the family environment is significantly different in families where there is one person with trichotillomania when compared to some families where there is not a person with trichotillomania.
Okay.
In short, that's what we found.
And I wanted to comment, you spoke earlier that how well designed this family study was. You made a comment about it being an excellent could you speak a little bit about that?
This is, as far as I know, one of the few family studies that has really spent a lot of effort and time trying to evaluate and get information about family environment. Many of the genetic family studies give lip service to, the environment is important, but really don't spend any time thinking about how to assess the environment. And this, with Dr. Kuthin's input, really focused on sort of family interactions and family dynamics, in addition to getting information about whether it was transmitted in families. And I might also say that we collected DNA samples, blood samples from all of the people who are willing to give us blood, so that eventually we'll be able to look at whether there are genetic factors, genetic tags that may give us some sense of what might be related to risk factors genetically.
Then the next question in this family study area is, what percent of the people in the family study you completed a few years ago came from a family with a high level of stress? For example, living in daily fear of a parent or of immoral physical abuses. Often such situations are deemed to be traumatic situations because of the deep harm they do to a person.
Well, as I said, part of our goal, or one of our goals, was to look at precisely that, what kind of things happen in the family that might be related. And what we found was that a measure of family relatedness, how well people get along together within the family, was much worse in families where there is a person with trick compared to control families. We also measured parenting stress and other measures of stress, and in general, almost across the board, mothers and parents, we had a few fathers participate, and the offspring themselves reported a much higher level of stress in parenting, in sib-sib relationships, when compared to families where there wasn't a person with trick. And one other thing was that, and this is only on mothers, and I should just add that we were unable to get very many fathers to participate in the study, so we focused mainly on mothers and their children. What our findings suggested is that there's a much higher level of anger, sort of persistent anger in the family environment. It's not episodic, it's not, we refer to it as state and trait. State anger is when, you know, you get mad and you blow off steam and then you're better and you apologize and everything is fine. Trait anger suggests that you're essentially angry all the time. And it may not really be anger as we think about it, but it is some level of tension and affects interactions that was there.
You know, something that I didn't know I was going to ask, but it comes to my mind, is the chicken and the egg concept. And I think for some people, they tend to think that the stressor in their lives is the trichotillomania. And then maybe that could cause stress for a parent. But in my experience, and I think what you're saying is, I need you to elucidate this, is that no, there's a stressor, and the trick seems to be an outcome from the stressor.
Well, you're right. It is a chicken and egg question, and we can't address the chronology in a family study that's it's a snapshot. So we ask about sort of retrospective experiences, but we understand that though the memory of those things that happened long ago are influenced, are colored by their current experience of having hair pulling or not. And so it's essentially impossible to tease apart what causes what. And I think it's probably a combination of both, and we have some data to suggest, to address that when you look at the correlation between some of these measures that I mentioned, anger and family relationships and conflict, and you look at whether levels of those factors are correlated with severity or correlated with distress, what you find is that the more conflict there is, the higher the severity. And the more conflict there is, the higher distress. And the worse the family relationship, the severity is higher in both severity and stress. So if there is a poor family dynamic, it increases, or it is correlated with a higher level of stress and distress in the person who is pulling.
I love your acknowledgement of the trait anger, because oftentimes I think that people have those kinds of, they're carrying emotions, but they don't even know it consciously. But it's coming out and the kids can read it, because I used to say, my mother's mouth says one thing and her body is saying another. And that's the example of trait, carrying that charge, but not even knowing it.
The difficulty and the caveat with every family study that is done, when you collect and recruit people from a clinic or from like the TLC, is that you are not selecting them from the general population. And so you're studying families where you already know there is a person with trichotillomania. So it's obviously skewed. In order to get rid of some of that skew, when you do the analyses about recurrence and the risk for trichotillomania in the family, you don't include the person who has trich who brought the family in. You don't include them in the analyses. You just look at the relatives. So that, and it's been shown in some very early genetic literature that pretty well corrects for that skew. But there's a different bias that you also mentioned in the second part, and that is the people who volunteer are not the same as the people who don't volunteer.
Right.
And there's no way that we know, there's no way we can tell whether these are the people who are less severely affected and don't have as much to hide, or these are the people who are really severely affected and really are searching for help and treatment, that would then skew it potentially. If severity is related to familiality, it would raise the risk. On the other hand, if the more severe, the people who had more to hide didn't volunteer, that would then skew the rate down if it was related to familiality. So, but unfortunately, we can't tell whether the people that we were able to recruit in the family study represent a sort of a random population of people who suffer with trich. My suspicion is that they don't.
It doesn't represent an across-the-board
Right.
group.
Right. My suspicion is that they don't represent the average person who pulls out their hair, but we don't know if they are more severe or if they're less severe.
And I'd like to ask, in regards to family studies, do you find this same conundrum with, other disorders?
It's true of every family study, that when you're collecting, the best way to do a family study would be to do a population study, select 100,000 families and study them, and then find out how many of them have hair pulling in them and how many don't. But doing a family study of 100,000 families, we did this family study cost $800,000, and we studied 100 families and 50 families of controls. So that's 150 families for $800,000. You can imagine how expensive it would be to do the same study in 100,000 families. You couldn't do it. It's too expensive. So it's true of every family study that you, and in fact, it's probably true in most genetic studies, because you're always ascertaining through an affected individual. Probably the only place where you don't have this kind of bias is in those twin studies where they're taking twins from a statewide or a nationwide registry, and they study all of the twins. Right. And that way you get a better sense of the prevalence of the condition and also the familiality of the condition.
And I have another question. You commented quite a bit on the high familial rate of OCD and some depression, things like that. But I guess I want to know is, in your personal experience with looking at family studies of Tourette's, OCD, Did you see the same kinds of differentials in terms of that more tension in the family or stress in the family with an individual or not? Or was that not even looked at?
As I mentioned before, we didn't have the same kind of measures for
Right.
stress in those
Right.
families.
Yeah.
We had some, and, there's some indication that it might be, but you really can't compare
No,
because we
no.
didn't do the assessments in the
Right.
same way.
Do you think that there were possibly patients participating in the family study who could admit to having trichotillomania, but for whom it was much more threatening to admit having experienced trauma in a dysfunctional family, and therefore were willing to come into you, say, I have trichotillomania, answer many of your questions, but avoid things that were too threatening for them to, or too revealing for them to bring out to you or whoever was doing the questioning?
I think definitely yes. When you begin to talk about early childhood trauma, early traumatic events in your lifetime, many people have a great deal of difficulty talking about those events, because if they start talking about them very often, they get flooded with the emotion of when the event occurred, and then really have a very hard time. They have flashbacks, and very much like post-traumatic stress disorder, that if you bring it up, it sort of brings up all of the negative things that they experienced at that time. So I'm sure there were people who were that way, that they were free to admit that they had trick, they free to admit that they had other conditions, but when we asked them about early traumatic experiences, they just said no. And they may have had them, but they just do not want to talk about them. And I think that's true, again, in any family study that you do. If you're beginning to delve into those kinds of questions, people are more reluctant to talk about them, just because of shame and fear of exposing the person who may have traumatized them.
Mm-hmm.
So,
Yeah. I came back from a conference taught by a 70-year-old psychiatrist or psychologist, and he was talking about Thomas Merton, contemplation, and healing from trauma. And we talked one-on-one, and he said, yes, you very seldom, just what you said. He said, you can't go directly, you can nibble around the trauma, but he said you can't go directly to the trauma, especially with an older person. He said, because it's too much pain, and it'll take probably years to untangle it.
Right.
Well, how successful was the testing at picking up cases involving trauma in the dysfunctional family, even though it wasn't admitted? Do you think it was successful that way?
We definitely found some people who admitted to having trauma, but again, as I said before, there's really no way of knowing how successful we were, because when the people didn't tell us, and if they had it and they didn't tell us, you just didn't know.
Yeah.
And that's true of even the people in the family who didn't have trick. We ask the same questions about everyone, and you have no idea of whether, when they say no, whether they really didn't have trauma or they're just too afraid to talk about it.
Or they're actually minimizing it as trauma and not,
Right.
because that happens sometimes where
Right.
people kind of minimize certain impacts and to make it easier to live.
Or repress memories of
Right,
it.
that's, yes, all of that.